A very good morning to all the chairpersons and the delegates. I'll be speaking on osteal-LAD thrombotic lesion angioplasty and the problems that we encounter with it. We'll start with a case presentation. A 55-year-old male, diabetic for 8 years, hypertensive for 10 years, known case of bronchial asthma on inhalers as required, also a smoker. He presented with chest pain for 3 days duration, worsening since the last 3 hours, associated with sweating and vomiting. On examination, his heart rate was 60, BP 100 and 100 by 60. Cardiovascular system was normal and lungs were clear. ECG showed a hyperacute anterior wall MI with ST depression 2-3 AVF and ST elevation in AVR, suggesting a very proximal or osteal-LAD lesion. His 2D echocardiogram on admission showed an akinetic septum, apex and anterior wall with a approximate ejection fraction of about 35%. In the ER, he was initially treated with a bolus of heparin 5,000 units, aspirin, prasugrel, and atorvastatin. IV eptifibatide infusion was started upfront, and he was shifted to the cath lab after all the consent and other procedures within 1 hour. Now, this is his initial angiographic picture. You'll see a large thrombotic burden in the proximal LAD artery with about TIMI2 flow into the LAD. And another important thing that you should see here that he's got a very large and dominant circumflex artery. Now, the problems with this sort of case, as we see regularly, especially if it's a total occlusion in the osteal-LAD artery, a few things that we had adverse events is basically a thrombus migration into the circumflex artery in a few cases. So in such cases, what we do as a routine now is, this is another view of the same thing. What was done for this case was put in a temporary pacing wire and also a filter wire into the circumflex artery to protect the large dominant circumflex artery against thrombus migration or embolism of the circumflex artery. After that, thrombus aspiration was done to the lesion with the filter wire in position, and that is the result post-thrombus aspiration. Then, since there was a significant residual lesion, a 2.5 millimeter into 15 balloon dilatation was done to the osteal-LAD artery, and this is the result post-balloon dilatation. A stent was positioned into the ostium of the LAD artery, confirmed in 2 views, and this is the stent deployment. And the final result after stent deployment and removal of the circumflex artery. Now, just a few things why we normally do this is, one thing is, over the many years, whenever there is a thrombotic total occlusion of the osteal-LAD artery, we have seen a few cases where thrombus migration or embolism of the circumflex artery can be catastrophic. Actually, over the last many years, a few of my colleagues and even myself have had complications with thrombus migration or embolism into the circumflex artery, causing cardiac arrest, and we lost a couple of patients. Though after rewiring the circumflex artery and thrombus aspiration, some of these cases have been saved. So as a rule, what we now do is, for total occlusions of the osteal-LAD artery, we now regularly put a filter wire into the circumflex artery. So in short, the take-home message is that thrombotic LAD osteal lesions pose a challenge for the following reasons. One is thrombus migration with the left main or circumflex, stent placement at the ostium without compromising the circumflex artery flow. So hence, for osteal-LAD lesion, the strategy of circumflex artery protection with a filter wire, thrombus aspiration, and treatment with triple antiplatelet therapy is most likely to prevent embolic complications and established TIMI3 flow.